Thank you very much. I appreciate Sages and the panel inviting me to share this topic. This is Volvulus. I'm a pediatric surgeon, so we're talking about malrotation. So this is going to be a malrotation volvulus talk. I think every surgeon, especially the adult surgeons, see plenty of volvulus, but that's more the sigmoid and cecal volvulus. I have nothing to disclose. So malrotation, it's abnormalities of rotation and fixation are of paramount importance and can be life-threatening. I'm a pediatric surgeon, so what I always tell the residents is pediatric surgery is embryology in action. So I will have to spend a few seconds talking about embryology in this talk. The incidence, it's not uncommon. It's 1 in 6,000 live births, and complete non-rotation has been reported in about 0.5% of the population in autopsies, 0.2% of asymptomatic incidental barium studies, and potentially, people talk about 1% of the population probably has some degree of rotational anomaly. So why is this important for the adult surgeons in the room? Anybody know who this is? My generation should, but this is Maurice Gibbs of the Gibbs brothers. I'm not saying they're a musical group, but he actually died at 53 from a classic volvulus or malrotation that was misdiagnosed. When I was a general surgery resident, I saw 3 classic malrotation patients as an adult resident in Cincinnati eons ago. As a pediatric surgeon, probably, next door, there's been about a half a dozen since the time. And I actually got called by a community general surgeon an hour away, wanted to transfer a 45-year-old he had on the table open because he says, well, I found malrotation, I don't know how to do a LAS procedure. I'm like, well, I definitely can't accept him to a children's hospital, so I talked him through it. And I think most of the general surgeons, I would imagine at least once or twice in your career you've seen this. So here's the embryology talk. So for the residents in the room, there's a zillion different, diagrams and stuff, but this is my favorite one. The wire is your SMA. The smooth rope is your duodenal-jejunal prearterial intestine. The rough rope is the cecal-colic junction. And by definition, there's a 270-degree twist. So there's 3 stages. The first stage, herniation. This occurs in the first, 4th week of gestation. All the bowels forming outside, and the duodenal-jejunal segment is growing quicker than the cecal-colic, hence the reason you have so much small bowel, and the colon is a certain size. At this stage, the bowel is twisting 180 degrees, and then it starts going back in, and that's returned to the abdomen, usually by the end of the first trimester, and the 10th, 11th week, and that's when it does its final 90-degree rotation, when it's going back into the abdomen. The duodenal-jejunal junction is fixed to the posterior body to the left of the SMA, and that's your ligament of Treitz. And then your cecal-colic junction is where your ileocecal valve comes from. And the final stage is its fixation, and that's where your peritoneal bands are, your ascending and descending colon, that's your white line of Tolt. And when any rotational anomaly, those are your LADS bands, is when that white line of Tolt, the signals are still there, and it blocks your duodenum. This is probably the classic one, I think what everyone needs to understand about it. The red dotted lines, that's your base of your mesentery. Normal, your ligament of Treitz should be left of the midline and behind your stomach, going to the right lower quadrant. Any rotational anomaly, whether you're non-rotation, I trained in Detroit, we're blue-collar people. It's like you're either pregnant or you're not pregnant, virgin. You either have a rotational anomaly or not. Doesn't matter if it's non-rotation. You have some degree where your mesentery is short, and that puts you at risk for volvulus. As I said, the classifications, all abnormalities of rotation and fixation, that's a malrotation. The non-rotation, that's first stage where some people are born and they've kind of had an auto LADS procedure done. And then incomplete rotation, that's the second stage, and that's later in embryology. But as I said before, you either have it or you don't, and that's the surgical decision when you identify it. The clinical manifestations, so the real life-threatening, the true surgical emergency, the acute midgut volvulus. It's the narrow pedicle. The mesentery is short, so that predisposes you to twisting. So when your ligament of Treitz is low, your cecum is low, that mid portion, that twists. And most of the time, as a pediatric surgeon, this presents in the first month of life. And anytime you have bilious emesis, now, we're all going to see bilious emesis, but pediatric surgeon, bilious emesis is malrotation to proven otherwise. Now, if they've had some upper GI or some documentation, there's plenty of other causes, but if for malrotation for this, bilious emesis is life-threatening. And then duodenal obstruction. So the chronic ones, those are your LADS bands. Those are the people sometimes, they have chronic pain, discomfort, and that's what's kind of causing that. And when you do your LADS procedure, you've taken care of that. Crampy abdominal pain, rectal bleeding, these are all end staging. I would say the rectal bleeding would be you're in trouble if you start seeing that. And then obviously peritonitis when they have dead gut. The chronic midgut valves, that's what I think most of the adult surgeons that we see. These are patients that have intermittent volvulus. It's much less common, but I've seen it probably a dozen times in the 25 years I've been doing this. There's lymphatic and venous obstruction, mesenteric nodes. When you get the CT scan, they kind of show these secondary signs. It's usually seen in children older than 2 years old and obviously adults. And then absorption and nutrient transport are impaired. That's rare. They have to have pretty significant things. And in this day and age, most kids are getting studied at the wazoo to prevent that. And then recurrent abdominal pain is a common symptom. And then there's the malrotation, the asymptomatic patient, and then that's the ongoing challenge for pediatric surgeons. What do we do with this finding? Everybody gets x-rays, 25%. I think there was a study back in the late 70s that 25% of all x-rays found something you weren't expecting. Wang and Welch, half the adults with findings actually had symptoms attributed to malrotation. So here are adults that got something and they actually had, when they did their last procedure, they had something that was a cause of it. Corrective surgery is generally indicated at any age when documented due to the risk of volvulus, which can be as high as 20%. So that's the ultimate thing. If you have a patient who you diagnose malrotation, they should get a LADS procedure. And I'll talk a little bit about some of the controversy later on. So x-rays, upper GI is your classic. You look for normal relations of the stomach, ligament detritus, and ileocecal area. Contrast studies is kind of the way to go. Your plain films, it'll show maybe a double bubble with a volvulus, but very nonspecific. Ultrasound is definitely getting more popularity, 2D, and what you see there is with a volvulus, the ultrasound will be able to pick up that SMA relationship and the whirlpool sign, that's an emergency. Get a stat upper GI, go to the OR. And then as the supramesenteric vein lies anterior to the left of the SMA, then malrotation, and you just want to follow with an upper GI. That's your gold standard. What you want to do here, the upper GI, you're going to look for abnormal right-sided position of the ligament detritus, so the ligament detritus doesn't pass the spine, or low lying. The normal ligament detritus should go to the left of midline and behind the stomach. The duodenal junction should be left of the spine. And then a volvulus, if you don't get any contrast and you have that bird's beak appearance, that's a volvulus to proven otherwise, which should be in the operating room. And this is what the contrast will show. I don't know if I have a pointer. There we go. Kind of stop there. See the lateral view where it's going past. And then this is one where it's going, then you're just squiggling on down. That's malrotation. Barium enema, sometimes you get that. 10% of the population will have a high riding right lower quadrant, but I do think barium enemas are good for the totally asymptomatic patient. You get a trauma patient, brings up. If you have a low-lying ligament, but across the midline and a normal place ileocecal valve, that deserves a conversation with the family of the pros and cons, and probably those are ones that will never have a problem. But barium enemas sometimes show the whole column on the left side, and you go through a thing, and that's your malrotation. So the treatment, and this is what I want to really kind of talk about for the adult surgeons who maybe not see it. This is a true surgical emergency. If you have a volvulus, don't waste time with anything else. Once you make the diagnosis, go straight to the OR. And then NG tube IV access, but these are ones you don't wait to resuscitate. You got to get in there and untwist that bowel. What the LADS procedure is, there's 5 steps. You eviscerate the bowel, you do a counterclockwise derotation, so it's usually twisted 3 or 4 times. You lyse the LADS bends and widen the mesenteric root. You do an appendectomy. Sorry, you always do an appendectomy. Screw to the appendix. And you place a small bowel on the right and a colon on the left. Now, this is SAGES. We do this laparoscopically. I'll talk about that in a second. But for a malrotation with a volvulus, I still think single incision surgery, nice big laparotomy. And I think most pediatric surgeons will agree with that. A true volvulus, you need to get that bowel out, eviscerated, and untwisted. And that's, in my hands, that's really hard, and I think it just delays things. So this needs a laparotomy. The LADS bands, and this is, I think, this is my personal bias. Again, the LADS bands are the white line of tolt, and it's blocking. So you have to basically do a full Coker maneuver. Rotational otomy's sort of done that for you, but you want to complete that. And those final bands over the duodenum, you have to really lyse those. And then when you're done, the small bowel should all be on the right, the colon should be on the left, and your mesentery should be flat. One of the other things with malrotation, you have a lot of these abnormal adhesions. You really want to take those down. You want that mesentery to be broad-based. I was always taught, and I still believe, you always do an appendectomy. When you're done, your appendix sits in the left upper quadrant. That's just a diagnostic impossibility, and I think the morbidity is super low. This is just diagrammatic things for that. But again, these are your LADS bands. It's the white line of tolt, it's obstructing your duodenum. So when you're done, so every malrotation is like a snowflake. It's a little bit different, but when you're done, this is really what it should be, whether that's laparoscopically or open. Volvulus with a midgut ischemia, immediate operation when suspected. Gangrenous bowel, if it's clearly dead, you take it out. If it's questionable, these are the classic, you pack, you bring them back, because this is the ones where you make them short bowel if everything is dead. And this time you start explaining. So this is the devastating thing. Obviously dead bowel, you gotta take it out. But for the ones that's compromised, do your LADS or just resuscitate them, get them twisted, get them resuscitated and bring them back in 24, 48 hours. Laparoscopic SAGES, I don't have a video, but a laparoscopic LADS procedure, very straightforward and easy. I would not do it for a volvulus. I think some people have talked about it. The controversy with laparoscopic LADS is part of the benefit of doing a LADS procedure is the scar tissue you create. It's still, the important thing is after you do a successful LADS procedure, you still have a 2% risk of a volvulus lifetime. It's rare, I've seen it twice, because you don't broaden the mesentery. And a laparoscopic, because it creates less adhesions, there is theoretical. I've not seen any papers, I've not seen any data, so I think a laparoscopic LADS in an adult, an older patient who has minor symptoms, totally appropriate. And then, but it's all steps of the procedure. You should be doing the same, like everything should be doing the same exact thing, but you're not doing this for a volvulus. The mortality, that's related to whether you have volvulus and dead gut. That's the whole mortality for a volvulus and a malrotation. Obviously, midgut volvulus sepsis and increased in the prematurity as a pediatric surgeon. Favorable outcomes are increased, obviously, the more quick you do it, but the mortality is when you have dead gut. The morbidity, and this is where there's a little bit of the controversy. So you have an asymptomatic patient. We used to, when I was taught, anybody have a diagnosis, you always do a LADS. The congenital heart disease kids, our cardiologists would get routine studies and say, oh, you got to do it, preventive that. LADS procedure does not prevent a volvulus, and I think that's the take-home lesson. And what's interesting is the LADS procedure actually has morbidity in terms of dysmotility. There is a higher incidence of small bowel obstruction with the LADS procedure for that. Recurrent obstructions, although part of that, what I've seen, so I do a LADS procedure. One of the adult surgeons say, hey, a patient was operated on by Dr. Goretsky. They can have a volvulus because that mesentery is short. So that's the important thing is don't assume anything. And then I think a lot of the chronic things that I've seen in the literature, I think a lot of it's due to if you don't really take all those bands down, really look at that picture where that mesentery is flat, that's going to be kind of the issue. But recurrent volvulus, like I said, 2% obstruction is higher than all other laparotomies when you look at the literature. Short gut syndrome is based on the taking the bowel out if they have dead gut from a volvulus. Factors leading to recurrent volvulus, inadequate adhesion formation, that's theoretic. That has not been played out when we were doing laparoscopic LADS now for probably, I'd say, a good 15 years, if not longer. And if the mesenteric base hasn't been wide enough, you're not going to widen it, but you want that flat. I think that's the key sign. And then GI motility disturbances. So like everything in surgery, it's my favorite textbook. If I have to answer any questions.